It certainly is a pleasure to be here with this group, some old friends, and I'm sure a number of people who have a lot of questions about this disease. Peritoneal mesothelioma has its differences from other malignancies, but it's very much the same in terms of outcome. If we can recognize this disease early and apply the definitive treatments that have been referred to by previous speakers, the outcome is extremely good. Perhaps 75% of people alive and well and disease-free at 5 years. Now, it's an incredible contrast to the thoracic mesothelioma situation. And actually, I think MARF deserves some credit, and now IMIG, also the International Mesothelioma Foundation, is beginning to recognize that this rare disease, a variant of a more common disease, is where we've seen a lot of progress. There's a problem, though. I mean, all three of our speakers here were from the East Coast. And what do you do if you've got peritoneal mesothelioma in the Midwest or on the West Coast? I mean, there's really no treatment center for the management of this disease outside of the mid-Atlantic here. And it's very unfortunate, and we do have a lot of people who come from a great distance, and it's very difficult for them and for their families. And we should have a better geographic distribution of the treatment centers throughout the United States. Now, that's only part of the problem. The other problem is most of the patients, and I'm not sure how many mesothelioma diagnoses there are each year, but only a fraction are treated with this multimodality approach that you've heard about here today. Most of the patients are treated with systemic chemotherapy for a while. They respond or they don't respond. Sometimes the referral does make it to a center of excellence where people are experienced in the management of this disease. But unfortunately, a majority of patients in the United States with peritoneal mesothelioma only get to a referral center, a place that's maybe managed 100 of these diseases in the past and has a team approach, a multidisciplinary approach that combines the best of surgery with the best of regional chemotherapy. So from my perspective, this is a disease where the cup is really half empty. So many more things could be done to improve the management of this rare disorder. They call it the National Association of Orphan Diseases, and because the people with these rare diseases are usually treated like orphans, like nobody really cares. I don't know why, since there's been, finally there's going to be a JCO, a Journal of Clinical Oncology manuscript, a combined effort from 5 or 6 from 6 different institutions where we've pooled our data, and now in one of these retrospective analyses, we're going to be able to show, okay, in 400 patients, when we treated them with this uniform treatment strategy of surgery combined with this hyperthermic intraperitoneal chemotherapy, we're looking at better than 50% survival at 5 years. Okay, so we accumulated 400 patients at 6 different institutions over 10 10 years, we should have accumulated many thousands of data points on patients with peritoneal mesothelioma, and we'd be all that much smarter about what we're doing. Now, you're going to say, oh, well, you should be organizing this attack on this rare disease where there is now a very well-established treatment strategy. And I'll tell you, the American College of Surgeons is not going to do it, and the American Society of Clinical Oncology is not going to do it. And I think that it's pressure from this type of group that's going to make a difference. It's going to have to come from patients and say, listen, you really need a treatment center on the West Coast, and you need a treatment center in the Midwest for excellence in treatment, for management of data, for a centralized molecular biological research approach to this disease. So maybe I'm just getting too old, but I think we can do a lot better, and I'm asking the people here and the organizers of MARF to think about trying to make this a more patient-friendly disease, because I can tell you it's extremely hard on patients from all over the country to come here and to be treated, and my hospital doesn't really have the wherewithal, to put the patients and their families up. And it'd be nice if we had a Ronald McDonald House and all that sort of thing, but we don't, and so they have to stay in a hotel, and it's not perfect. It really is far from perfect. Now, the question and answer part of this is definitely the most important, and with my few preliminary remarks, we're already over time. So I'm going to show about 2 slides, and then I'm going to stop. The next slide, please. I think I have it up here. Now, just look at this. And look at the last column there, the median survival. 10 months, 15 months, 9 months. This is old data, of course, coming back out of the 1980s. This is before we used both surgery and this hyperthermic intraperitoneal chemotherapy to treat the disease. And then, look what started happening. And just look down the list of reports, the year in which they were studies were reported. This actually is one of Rich Alexander's reports early on, and we finally jumped out of the 2-year median survival above, and we're down to 5-year median survival. Now, there are no randomized controlled studies, and there never will be. And if the medical oncologists keep asking for evidence-based medicine, they're not going to get it. But the standard of care for this disease is surgery performed by an experienced and knowledgeable oncologist, surgical oncologist, and then the hyperthermic intraperitoneal chemotherapy. Now, not all patients can be treated because some come to us very late, unfortunately. And the later they come, this disease builds up in its aggressiveness over time. If there's a delay in referral and in definitive treatment, things don't turn out so well. Okay, my last slide. This is how patients have done at the hospital center. This is 100 patients. And, about half the patients are doing well. Now, let me just tell you one little vignette before I stop. There's one group of patients where the referral comes early while the disease is still in its infancy, in its young women. And usually because of an ovarian mass or problems with menstruation, they go to their gynecologist, and they have a diagnosis made early in the course of the disease, before all the ascites builds up and there's an omental cake and that sort of thing. Those patients do incredibly well, and the survival on those group of patients is way up here in the 80% range. So I'm going to leave you with two thoughts. Number one, this disease needs to be diagnosed early, if possible, and referred for definitive treatment. We have a definitive treatment for the disease. It maybe will improve, and all the centers here have clinical trials going on in order to try and make some improvements. Number one. Number two, it needs to be available in a more regionally distributed manner throughout the United States. And exactly how to go about that, I'm not quite sure. It's a political issue. It's a medical economics issue, but I think that MARF can be of help to us in this regard. Thanks very much. It's been a pleasure to be here. I really look forward to the good questions.